Hello, Etienne, if you're hearing me. Hello, Etienne, if you're hearing me, could you please turn on your camera? And we'll do a quick audio test, if that's possible, and then leave your camera on, if that would be fantastic. I'm just seeing black from you. There we are. Now we see you. Are you hearing us okay?
Hearing you, yeah. Can you hear me?
Yep, perfect. So if you could leave your camera on now, sir, that would be fantastic.
Sure.
Okay, for those online, I think we're going to open up this webinar to our journalist colleagues at this point, because we're about 3 minutes past our start time. We've got quite a few people here. Others are on the way, I hear, so we should be starting in not too long. You can reach out to me in the chat if you have any questions or on the Signal group. And I wish you a good press conference. Thank you for your time and good luck. Etienne, I'm just going to mute your audio. You can unmute when it comes time to talk, okay?
Recording in progress. Hello and welcome to today's press briefing out of WHO Geneva's headquarters. It is Thursday, 16 July 2026, and my name is Christian Lindman. I will walk you through this next hour or so. We'll discuss a couple of topics, and I will start with introducing the panel here in the room. First and foremost, we have our Director General, Dr. Tedros Adhanom Ghebreyesus. On his side is Dr. Ghebreyesus, Executive Director for WHO's Health Emergencies Program. Next to him is Anaïs Legon, Technical Officer for High Threat Pathogens, also at the Emergencies Program. Then we have Dr. Neerja Chowdhury. She's Technical Officer at the Neurological, Sensory and Oral Conditions Unit. On the other side of Dr. Tedros, we have Dr. Kate O'Brien, Director for Immunization, Vaccines and Biologicals. And last but not least, Dr. Vasim Murthy. He's the acting lead for the R&D blueprint in the Office of the Chief Scientist. We should have a couple of other colleagues online. Some couldn't make the connection yet, and I'll introduce them when we come to that point. Again, once we're through the introductory remarks, we'll open the floor for questions and answers. And if you want to get into the queue, please raise your hand with the raise your hand icon. Or of course, here in the room, welcome to all journalists. You know the drill, please raise your hand. With this, thank you. Enough from me, and over to Dr. Tedros.
Thank you, Christian. Good afternoon to those in the room, and good morning, good afternoon, and good evening to those online. Yesterday marked 2 months since the government of the DRC declared the epidemic of Ebola. Since then, the outbreak has expanded rapidly. It's now the third largest Ebola outbreak on record, and in the past months, it has expanded faster than any previous outbreak. So far, 2,073 cases have been reported with 796 deaths. By comparison, the 2018-2019 Ebola outbreak in DRC took more than 10 months to reach 2,000 confirmed cases. Intense transmission in the province of Ituri remains our biggest concern. More than 80% of new cases are being detected outside known contact lists, showing that transmission chains are still being missed. About 2/3 of deaths are occurring in communities among people who never receive care in a health facility. Together with Africa CDC and other partners, WHO is supporting the government to scale up the response. Treatment capacity now exceeds 800 beds and continues to increase. Laboratory capacity has expanded from just 1 lab to 16. Contact follow-up rates have increased to almost 80%. More than 21,000 community workers are being trained. And safe and dignified burials have improved significantly. There is also encouraging progress on vaccines and therapeutics. Earlier this month, we began a clinical trial of 2 treatments, the monoclonal antibody MBP13 and the antiviral drug remdesivir. On Monday, the first safety trial began of the ChAdOx1 vaccine led by the University of Oxford. And on Tuesday this week, partners led by DRC's National Institute for Biomedical Research launched a trial of the antiviral remdesivir as post-exposure prophylaxis in people who have been in contact with confirmed cases but have not yet developed disease. Even without approved vaccines and treatments, 377 people have recovered, showing that with early diagnosis and safe care, this disease can be survived and stopped. In Uganda, the last confirmed case is being discharged from care today, starting the 42-day countdown to the end of that country's outbreak with 20 cases and 2 deaths. Despite the progress we have made, the outbreak in DRC is continuing to outpace the response. active armed conflict is hampering access to the affected areas and hindering the response. Just yesterday, a treatment center in Bunia was attacked. We face several technical challenges, but we also need political intervention to facilitate the scale-up in the response that we need. Our priorities are to reduce transmission in Ituri by strengthening surveillance, safe and dignified burials, clinical management, and community management, and by strengthening response capacity in newly affected provinces before transmission becomes established. But to do this, we urgently need the support of the international community. We still face a shortfall of more than $400 million in the joint WHO Africa CDC Continental Preparedness and Response Plan. We urge donors to fill this gap and to help us to control this outbreak as quickly as possible. This is not charity, it's an investment in national security. While we don't have a vaccine for Bundibugyo virus, there are many other one-sphere diseases that can now be easily prevented with vaccines, from measles to polio and cervical cancer. Yesterday, WHO and UNICEF published our annual estimates of the levels of immunization coverage in countries around the world. In 2025, 90% of infants globally received at least one dose of diphtheria, tetanus, and pertussis vaccine, and 85% completed the full 3-dose series. Both measures are slightly higher than 2024, but still below 2019 levels and within the same narrow range since 2009. Even before COVID-19, immunization coverage had stalled globally. The pandemic disrupted routine immunization systems, reversing gains. In response, WHO, UNICEF, and Gavi launched the Big Catch-up to reach children who missed out on one or all routine vaccines. Over the past 3 years, we reached more than 14 of the 34 million zero-dose children, delivering more than 125 million doses in 36 countries. Thanks to the Big Catch-up, we have recovered the ground we lost. However, our new data show there were still an estimated 13.5 million zero-dose children under 1 year of age who did not receive single vaccine in 2025. While this represents a small improvement on the previous year, it's far short of the target that countries set for themselves to reduce the number of zero-dose children to 6.4 million by 2030. And the gains we see are undermined by a rising number of children who receive one dose but do not complete the full immunization schedule, leaving them insufficiently protected. Vaccines are among the best investments in public health, health security, and sustainable development. They pay a rich dividend in lives saved, in healthier, safer, and more productive populations. WHO calls on all countries and donors to invest in reaching the 2030 target, including by fully funding Gavi. Vaccines are especially important for protecting children in the earliest years of life. At the other end of life, many countries are confronting an increasing burden of dementia and cognitive decline with aging populations. Dementia is among the greatest health and social challenges of our time, touching people, families, and communities everywhere. More than 57 million people live with dementia worldwide, and almost 10 million people are newly diagnosed every year. Alzheimer's disease is the most common form of dementia, accounting for 60 to 70% of cases. While there is no cure for dementia, it can be prevented or delayed by avoiding risk factors, including tobacco, alcohol use, social isolation, physical inactivity, air pollution, and by treating high blood pressure, diabetes, and hearing loss. Yesterday, WHO published updated guidelines on reducing the risk of dementia and cognitive decline, providing practical, evidence-based recommendations. Protecting brain health is not the responsibility of the health sector alone. It requires coordinated action across governments, communities, and systems. WHO calls on all countries and partners to integrate dementia risk reduction into primary health care and programs for non-communicable diseases, mental health, healthy aging, and community health. Finally, on Monday next week, United Nations member states will meet in New York for the high-level meeting on road safety. We expect member states to adopt a strong political declaration, which they have been negotiating over the past few months. It commits them to implementing national road safety strategies with clear targets, timelines, and budgets. The draft declaration also includes commitments to establish road safety agencies, improve data collection, develop and enforce strong laws, and ensure infrastructure and vehicles meet key safety standards. It also commits countries to adopt the proven safe systems approach, which accepts that people will always make mistakes on the roads, and so designs roads, speed limits, and rules around levels the human body can survive when a crash occurs. To coincide with the meeting, WHO will also publish a new report next week showing encouraging progress in road safety, although insufficient to meet the global target of a 50% reduction in deaths and serious injuries by 2030. Christian, back to you.
Thank you very much, Dr. Tedros. And with this, we'll open the round of questions. And again, please raise your hand with the raise your hand icon. Let me look around the room first. That's where we start. And we have Catherine Fiancon from France 24.
Yes, thank you, Christian. Good afternoon. I have two questions. My first one is regarding Ebola. And I'd like to know how you explain the fast growth of cases. Is it linked to the increase of testing? Or do you see any other reason? And also, I'd like also to ask a question about preparedness, because there's a lot of preparedness in the field, but as Ebola symptoms are look much like malaria or fever, typhoid fever, they could make confusion. And don't you think that, in fact, the workers should be more trained about non-common diseases? Thank you.
I have a range of questions here, and we start with Dr. Ghebreyesus.
Thank you, Catherine. On your first question on the increase in number of cases that we've seen recently, and we have seen very high numbers every day, sometimes up to 80 cases per day. I think on average we're seeing about 50 cases on single days. There are two explanations for that. The first, obviously, is we have intensified all aspects of the response: surveillance, lab testing, increased the number of laboratories to 15 in the outbreak-affected provinces. A lot of work is happening in communities to bring in cases, to sensitize them to the opportunity of care. And therefore, there's a lot of work happening across, and that has led to some increase in testing. I think we're doing over 2,000 tests on a single day right now across the provinces. However, this is not enough. We're in the Ituri province, which remains the heart of the response, especially in the 5 health zones: Mongwalu, Rampara, Bunia, Nizi, and Nyakunde. We're seeing just too many cases that don't make it into the health facilities. So they are either presenting on their own to the health centers or, unfortunately, passing away before they present to care. So at the moment, 60% plus minus of deaths are occurring in the community. So of all the cases that we report every single day, 60% are happening in the community. So if you imagine there are 50 new cases in a day, 30 to 40 of them would have been ill, most likely for weeks, and passed away in the community without approaching care at all, and would only be diagnosed because we take swabs just before they're buried. So at the heart of this response right now is getting cases into care. This is our primary focus across all the outbreak-affected areas. We've built up new beds. There are over 800 beds available at the moment. Many partners are working on this. Your chances of survival are 3 to 4 times higher when you come into care. So we have at the moment a case fatality ratio of about 30 to 40%. If you look at those that come into care, it's about 10 to 15%. If you look at those that die in the community, it's about 60 to 70%. So your chances of survival are so much higher. So all the efforts by all the partners right now to get ahead of this is really focused on bringing patients into care as quickly as possible. And that's the most important message that we have. Across the response, the facilities have improved, healthcare workers have improved, the entire ecosystem of providing care has improved significantly. So we're working very hard, Catherine, to make sure that people have confidence in the care being provided and take advantage of the opportunity of survival.
Thank you very much.
On your second question, on preparedness, just to say that this is a complex set of circumstances. I think one good point is the government of the DRC has offered free healthcare to everyone presenting to hospitals and clinics in the outbreak-affected areas. This then covers not only for, of course, Ebola, you'll already be treated for free, but also covers all other healthcare other diseases. Now, that's not the only solution, but that's one. Of course, we can't solve all the challenges of a health system in the 2 months of an Ebola outbreak, but we're very much focused on making sure that all the other essential health services being provided in this community are also available for anyone presenting. But it's a long game, and the issue of preparedness is multifocal, and we have to keep working on it, because if people living in a community are not confident that the system will take care of pregnant women, children with malaria, children with measles, there's no reason we expect them to come because we tell them there's an Ebola outbreak. So this really shows the connection between health systems, prevention, promotion, and of course, health security and our response when it comes to an Ebola outbreak.
Thank you very much for this. Next question is also here in the room, and please introduce yourself briefly.
Thank you, Christian. Taha Youssef, AP Middle East media outlets. My question is, why didn't you declare Ebola pandemic like you did with Corona?
All right, let's go into the definition of pandemic, epidemic, outbreak. Anaïs Legon, please.
So I'm not an IHR expert, and definitely not with the revision of 20. So the emergency committee outlined very clearly why it constituted a fake, focusing on the impact for affected communities and focusing on the specificities of this disease. Again, I'm not a legal expert there. But the emergency committee didn't think the criteria were met. But as you know, the emergency committee meets every 3 months to review the situation and to look if this event still continue effect. So next 3 months will be in August, the latest 22nd of August, where this will be likely discussed.
Thank you very much. Then we go for the first question online, and that's Helen Branswell from STAT. Helen, please go ahead.
Hi, thank you very much for doing this, and thank you, Christian, for taking my question. I'm going to ask a couple, if that's okay, and can you hear me all right?
Yes, good.
Oh, good, thank you. The first is about the Marburg outbreak in Uganda. We've heard nothing about that for a while. Have there been additional cases? Is WHO concerned that there might be additional transmission, or does that seem to be under control? And my second question relates to the fact that, we're now 2 months into the Ebola outbreak. This is the biggest Bundibugyo outbreak on record. A lot must be being learned about how this version of the virus is different from Zaire and Sudan. And I'm wondering if there's any indication that there's differences with this virus that are making it harder to control. Thank you.
Thank you very much. Helen, do we start with? All right, then we start with Margot, with Dr. Ghebreyesus.
Yeah, thanks, Helen. On the Marburg situation, we know the Ministry of Health in Uganda is investigating that. They haven't reported anything new to us. We've sent several additional requests for information, and we're still waiting to hear from them specifically on the outcomes of the investigation that we know that they're carrying out. So we'll make that public as soon as we hear. We've sent frequent and repeated requests to the government of Uganda, and we're waiting on them to respond to the IHR request that we've sent to them. So we'll update as soon as we have anything further. I'll pass to Anais.
Yes, thanks a lot. So on the question whether or not we are looking into if there is difference around the different species among the genus Ortho-Ebola virus, yes, we are, obviously. When I say we, it's obviously working with the Ministry of Health, Institut National de Recherche Biomédicale, surveillance team, clinical management team, and others, and sequencing as well. You can see that a number of sequences have been released already to see what makes this outbreak, this dynamic, and how we can control it. So I would say the most obvious difference that we are seeing compared to Ebola virus or Sudan virus from the data that we have now, but also data that we had in 2007, and 2012 is around the case fatality ratio, which seems to be lower for this species of viruses. So does it have an impact on how people react in terms of urgency of isolation, early admission to care, this kind of thing? This may have an impact. I'm not saying it has. I'm saying this is among the hypotheses that are being studied. And obviously at treatment center level, but also through the investigation, symptoms are recorded to see if there is major difference. There was a preliminary paper that built on early data, but is not sufficient, unfortunately, to tell us if there were or not difference. There were no major difference in terms of symptom presented at admission, but more is needed to definitely understand that. For the moment, it seems comparable to what we've seen in 2007, 2012 in terms of virus characteristic, but as you realize, obviously context is totally different into which settings this virus and what population it affects, meaning populations that are suffering decades of conflicts and a number of other crises. I hope I answered the question.
Thank you very much. And Dr. Tedros, please.
Yeah, the other angle that makes the Bundibugyo outbreak difficult, making it harder, as you said, Helen, is the complex environment in which the outbreak is happening. As you know, there is active armed conflict in Ituri, and of course, Eastern DRC in general, and especially the epicenter Ituri. I said it in my statement, there was attack yesterday, And there are frequent attacks actually since the end of 2025. The armed conflict has intensified. That means access is difficult, but not only that, following up on contacts is also difficult. So that environment is one, I mean, the conflict is one. And second, because of the conflict, there is displacement. So following up on contacts is difficult. And then, of course, the camps, because of the conflict, there is displacement. Recently, more than 100,000 additional people have been displaced on top of close to 1 million that have been displaced in the past. And that makes the response also difficult, and it's a very big mining area, and there is serious mobility. It's massive mobility, and that makes it harder as well. And due to this chronic conflict and other factors, the community mistrust is also serious. I have been to Beni during the 2018-2020 outbreak. I have traveled there many times. But compared to this one, I think Beni is nothing. North Kivu was nothing, especially the difficult environment that makes the response really complicated. So that's why we have been asking for our political leaders to also address that part, because this is not a technical issue alone. Of course, there are technical challenges that should be addressed, but there is the other side, which I have already outlined, which should be addressed as well. So it's harder, but I cannot say it's impossible, because especially if we focus on communities, if we focus on communities, on reclaiming community trust, of course it will take time, and that could change the tide. But of course, support from the political leaders, especially in addressing the security issue, humanitarian corridors, and permanent or temporary ceasefires. So the situation should be seen in its totality, not in isolation. And we have to address all factors that contribute to the outbreak. So with that, Christian.
Yeah, thank you, all three of you, and Dr. Tedros. I think we go the same direction now. Let's see. We have Kai Kupferschmidt from Science. Kai, please go ahead.
Hey, Christian. Thanks for taking my questions. Two, if I may, on the clinical trials. So, first of all, one of the drugs being tested in the partners trial is MBP134, and we've talked in the past about the question: is there going to be post-trial access? Is there any effort to produce more of the drug? So I wanted to ask where that stands, and whether there's any assurance of post-trial access. And then the other thing is, more generally, with these two trials that have started, obviously, EBOPEP is going to be hard if the contacts that you want to treat aren't on contact lists, and and treating patients won't be possible if people are dying in the community. So I'm wondering if there's any specific things that are being done to try and solve these issues, at least in the ETUs that are starting with these trials, and I assume you want to expand them to other ETUs. So what are currently what's the thinking about how to address these challenges in general, but especially in these clinical trials?
Thank you very much, Kai. And I think we start with Dr. Vasimoti, and we have a special guest also online here who we will introduce.
Thank you for the question, Kai. So I will start on the question about MBP134 and post-trial access. And then for the Ebola trial, we're fortunate to have Dr. Yazdan Yazdanpana, so I'm going to hand over to him. On post-trial access, this is completely central. And as WHO has highlighted, we unfortunately don't have the same ecosystem for the end-to-end that we have in vaccines, where with CEPI, WHO, Gavi, UNICEF, we really do have the entities in place to fund on the R&D side, the clinical trials, including the post-trial access. This is, let's be clear, this is a gap for therapeutics. We need to fix it. So what has to happen right now, until we put in place the full ecosystem with the partners designated to receive funding on the throughout this end-to-end, is that we need to talk to all of our partners to do whatever we can to ensure post-trial access. So this is the current arrangement. When we start these clinical trials, we have contracts with any companies. So the R&D Blueprint Technical Advisory Group prioritizes the therapeutic agents as well as the vaccines later on. And then we do, and in this case, we're a sponsor of the trial, so we have contracts with the companies, and in those contracts, they are required to pursue all avenues to ensure post-trial access. But where we are right now is that partners, and I can't go into too many details because it's really for those partners to explain what they're doing. We have stated that we expect those who are dispersing funding to support additional manufacturing, and we know that we're thankful to the US government for the donation of doses of MBP134 to the trial. They are supporting the trial, but in addition, we do need further doses manufactured, and there are multiple partners, partly at our instigation, that are in discussions with the manufacturers about proceeding at speed with post-trial access. And we have been informed that there is not going to be a gap for post-trial access. That manufacturing is underway, those discussions are underway. UNITAID is playing an important role in laying out an access roadmap, both for MBP134 and for obeldesivir in the prophylaxis trial. So they have an important role. But going forward, we really do need to have more clarity about how all of this is going to be done without us needing to engage in these somewhat ad hoc discussions in the middle of the outbreak. For the prophylaxis trial, I'm going to hand over to Dr. Yazdan Yazdanpana. He's the head of the French National Agency for Emerging Infectious Diseases Research and Funding Coordination, and they are the lead collaborative open research consortium for filoviruses. WHO has a network of these, what we call CORCs, research institutions that we decentralize scientific convening to. They're the lead for filoviruses, and they are the co-lead of the prophylaxis trial with INRB, the National Research Institution, National Biomedical Research Institution of DRC. So over to Dr. Yazdan if you're on the line.
Yeah, thanks a lot, Vazi. So good afternoon, Dr. Tedros. Good afternoon, everyone. So thanks a lot for your question. So EBOPEP trial is a clinical trial of obeldesivir versus placebo as post-exposure prophylaxis for highly exposed people, contacts to Ebola cases. And the question that has been asked is very important because this trial really relies a good contact tracing. I think the DG in his introduction told us that this is getting better. It's about 80%. It is not yet maximum, but we think that having a medication for post-exposure prophylaxis would make this even better if we show that we have a medication and we have an efficacious treatment. So that's why this trial is extremely important. But first, we should show that it is efficacious. And for that, we rely on contact tracing. This is a difference with a treatment, actually, trial, because we really rely on contact tracing. For this, we, of course, closely work with INSP colleagues, with WHO, Africa CDC colleagues. And you asked the question, what are things that have been implemented? One very important, actually, thing that has been implemented, but I think we're going to see how we will improve it, is to rely on the community champions. That is where involving the population since the beginning in the clinical trial conception, and also in the way we are going to build things was very important. So we have done this since the beginning. We are trying to have champions within the community to help us. The clinical centers for the protocol are close to the CTUs so that when the cases are identified, we identify the contacts. And for identifying the contacts, to rely also on our community champions. I'm not saying that everything is now excellent, but I think that it was said, it is really just started. We know that this is an important point to work on. We rely on community workers for this, and we're going to try to improve things. Over.
Thank you very much, Dr. Murthy and Professor Yazdan Panam. Thank you. Next question goes to Jonathan Lambert from NPR. Jonathan, go ahead.
Hi, thanks for taking my question. It's sort of a big picture one. It seems like significant progress in scaling up the response in DRC to this outbreak has been made so far, but it's just not enough to keep up with the growing epidemic. Given the major budget shortfall that you were talking about earlier, I'm wondering how you're thinking about sort of the biggest priority right now. Is it increasing surveillance and contact tracing to bring down the number of cases being detected outside of those contact lists, or increasing treatment capacity? I'm just kind of curious how you're thinking about which components of the response could provide kind of the biggest impact given limited resources and the kind of external factors like conflict that make responding even harder. Thanks.
Thank you, Jonathan. The big what to do first question, Dr. Ghebreyesus, maybe.
Thank you very much. From the scale that we just heard from the DG's speech, we don't have the luxury of choosing one aspect of the response over the other. So we know what to do. We know the geographies that are primarily affected. We need to do everything collectively at speed, at scale. There's no other way around this. Ebola doesn't allow you the opportunity of choosing whether to focus on X or Y. You have to do it collectively, do it consistently, and not drop the ball at all. And that's what we're trying to do. What this means is, firstly, led by the government of the DRC, which they are pushing very hard in the areas most affected, following up every single case that we can find, all their contacts, following up every contact consistently for 21 days. There are about 15,000 contacts on the list at the moment. Each of them is followed up. We're at about 80% of coverage, trying to make sure we get to everyone every single day. Like you heard earlier, all of this is not enough. Not that we're not following up the contacts that we know, but we're not finding all the cases that exist. So this is a collective effort that needs to happen. In terms of the costs, whatever it costs us today, as expensive as it is to all of us, the country, all the partners, the global community, it will cost multiple times what we're spending at the moment if we don't get ahead of this at the moment. So like DG mentioned, the resources available for the response, let's set aside the financial constraints on the organization and other responding organizations. The needs to respond specifically to this response on the strategic preparedness and response plan that we announced to the world is only 30% funded at the moment, maybe even less. So leave aside the broader challenges that we have. The fact is, how serious does the world take the outbreak that we're facing at the moment? How much are we ready to stand in solidarity with the colleagues responding, irrespective, despite the humanitarian challenges around, and really stop this outbreak now that it's still mostly contained within the DRC. If we don't do what we need to do now, it will take us more effort, it will cost us more money, and it will take a lot more lives. So really, we are intensifying our response collectively. The government is leading on that intensification. All the partners are working extremely hard on this. And what we need now across the world is really solidarity by all countries in supporting the DRC, not just as support to the DRC, but all in our enlightened self-interest to protect ourselves from the consequences of this both in health, in resources, in financing, and just in terms of the socioeconomic stability in the region and beyond.
Thank you very much for this. And I'm going to add one which D. Jovanovic from ABC News sent in writing because they can't get to the microphone because it fits at this point. Let me read it out. Uganda has discharged its last patient, started a countdown to end the outbreak, but DRC is still ongoing and fighting. What does success look like, and how do we stop the virus from crossing borders yet again? So the big question, how does success look like? I want to throw that back to you, Dr. Ghebreyesus.
Yeah, the success with every Ebola outbreak is there's no ambiguity about it. We have to get to zero. So there's no 99% success when you're fighting an Ebola outbreak. We have to get the cases down to zero, and that's our objective and what we're still focused on, and we know we can do it.
Short and sweet, thank you very much. Next one goes to Jacob Reed from Bloomberg. Jacob, please go ahead.
Hi, thank you. Jacob Reed from Bloomberg. My question is about the DRC's travel policy. The government requires anyone who's been in the epidemic zone to spend 21 days in a non-epidemic area before leaving the country. Is that potentially hampering the response by restricting the movement of international medical workers? And with Dr. Tedros due to visit Bunia, will he be required to spend 21 days outside of the epidemic zone before leaving the DRC, or is he exempt? Thank you.
Yeah, good point. Where do travel restrictions come in place? Dr. Ghebreyesus.
So thanks. I think firstly we have to remember why the government of the DRC put in those restrictions in the first place. They were reacting to the case, a health worker that got confirmed in France, and they were anxious about the consequences on the country should countries impose trade and travel restrictions on them. So I think the first thing we have to recognize is why they did this. And I think it's our collective responsibility to reduce the anxiety by the DRC, by countries around the world, not threatening countries with trade and travel restrictions, following the recommendations of the emergency committee that has been set up. And if we adhere to those recommendations, we will manage the risks very effectively as much as we can of spread outside of the DRC. Coming to the restrictions itself, this was a measure taken by the government of DRC. We are working with them. They are working with us to approach this from a risk-based perspective, dependent on exposure of individuals to scenarios that may increase or decrease the risk of them contacting the virus. This is not only for internationals or people in the response, but also affects people traveling within the country from the outbreak-affected areas to others. So we're working very hard together. They are very open to working collectively to find a balanced and nuanced approach to this that protects the health of people in the response, but also enables and facilitates the entry and departure of colleagues coming in to support them from around the world, which they've been very welcoming of and collectively working with towards the control of this outbreak. So far, we've managed this fairly effectively. Exemptions have been given where it's appropriate, but we're working towards a longer-term resolution to this challenge.
And thank you very much again. Then let's go with Belisa Godinho from W Magazine. Belisa, please go ahead.
Thank you. I'm Belisa Godinho from W Magazine Media in Portugal. Before I ask my question, if allowed, I would like to brief highly that over the past months worldwide, both medical professionals and journalists, myself included, have faced constraints that affect our ability to work as usual. In my case, I lost access to WHO platforms in April. My media outlets' website were taken down. More than 15 emails, professional emails, were blocked in May. only 5 were recovered. And in June, I experienced personal and professional digital intrusions that disrupt funding and travel plans for World Cup coverage in local events. These incidents raise important questions about interference in global health reporting.
Belisa, can I please ask you to ask your question? Thank you for that statement,
Yes.
but this is not a
So,
platform for statements.
given these concerns, my question is, WHO is confident that countries are providing timely, complete, and transparent surveillance data on suspected and confirmed cases among World Cup travels. And has the organization identified any gaps that could compromise international health security? Thank you.
You mean in general whether health security globally could be compromised? I'm not sure we understood your question here.
Is related to the transparent and surveillance data on suspected and confirmed cases related with World Cup travelers, and in general too, if the organization.
Belisa, please send that question to us in writing to media@who.int. I'm not sure we're getting the gist of this here. Thank you. So media inquiries at who.int, and we'll get this treated. Thank you. Next question, we go with Dominic Hughes from BBC. Please go ahead, Dominic.
Hi, Christian. Thank you very much for taking my question. I just wanted to ask, I totally get the difficulties around knowing exactly how many cases there are, but given that the latest data is 2,073 cases in DRC, what do we think the real number might be? I've read that some experts believe it might be twice or even 4 times that number. And also, how great is the risk that this outbreak will spread to, for example, South Sudan and other neighboring countries, and what would happen then? And fundamentally, is this outbreak out of control at the moment? Thanks.
Yeah, very good questions. Let's see where we start. We have Anaïs Legon, and unfortunately we tried to have our head of country office online, but the connection didn't work out. So we tried Dr. Anancia, the WHO representative in Congo, and DRC, sorry, but unfortunately not. So Anaïs Legon, please.
You're stuck with me. So to your points, because there were several. The first one is the estimate of the number of total number of cases. It's always it's often complicated to get the good grasp, but teams are ongoing and scaling up obviously case finding, but also testing of community deaths, because it can give us also a good estimate on potential cases that are missed. We've read also this report saying that the outbreak is likely underestimated, but some work is ongoing to better characterize it. So I'm not a modeler either, so on my side I will not take this exercise. But to your point on what is the risk for South Sudan, this is why preparedness and readiness is ongoing. This is why WHO and other partners support countries that may be at risk of patients going to other countries for better access to health or for any other reasons. That's why we are supporting neighboring countries to scale up ability to test, early detection, training of healthcare workers, and adequate case management and these kind of things. So it's in terms of looking at the risks, there are also a number of assessments looking at mobility pattern to ensure that there is good understanding that at point of exit and point of entry, there is sufficient information to travelers to recognize early and report if they have symptoms at the border. I forgot the third question. I'm sorry.
And Dr. Ghebreyesus.
I can take the third one. He asked if the outbreak was out of control. So firstly, let me just say, I just got back from Bunia and Beni in the DRC. And what I saw was really an incredibly committed set of healthcare workers going out every single day to provide care. If you go to the treatment centers, you see them working very hard, coming out, going back in. Like I said earlier, we have 2,000 tests being done a day. We have over 30 safe and dignified burials happening every day. This means when they're called, the burial team comes together, gets its IPC materials ready, drives to the location, sometimes through difficult roads, difficult terrains, and goes and delivers a safe and dignified burial for that community. There are lots of healthcare workers going to every single health facility in the area, offering them infection prevention and control facilities, equipment. Every evening, we would gather in a coordination meeting led by the Ministry of Health. We would assess what we did the day before and plan for the next day. So this is actually a response that is maturing, with a lot of committed colleagues working very hard on this every day. I did not see an outbreak that was out of control. I saw a very difficult situation with determined colleagues working very hard every day to respond to it. So we are facing a very difficult situation, no doubt about that. It is not out of control, but we need to work very hard and consistently into the next few weeks and months to get ahead of this. This will be a marathon. We don't want to leave this room with anyone imagining that we will manage this in the next few weeks. It will be a marathon, so we will need patience, but we'll also need the support and resources to plan for the marathon that we all have to face together.
Thank you very much, both, for these answers. And with this, we've come to the end of, to the top of the hour and to the end of our briefing today, which turned out to be a purely Ebola briefing, which is in fact good because it shows the interest is still there, and that is important because, as we heard many times today, this has only just started. The sound files and the video files will be shared soon after this briefing, and the introductory remarks by Dr. Tedros. I thank all the colleagues who have been online and here in the room. Thanks for your presence, and apologies to the journalists who we couldn't get to any more. With this, back to Dr. Tedros for closing.
Thank you, Christian. Thank you to members of the press who joined us today here in the room, and also those online. And see you next time.